Neither the El Paso County Medical Society, its members, nor KCUS TV shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Good evening. There are many different types of neurological conditions. Neurosurgery is dedicated to the diagnosis and treatment of issues affecting the nervous system, and that includes the brain, the cervical spine, peripheral nerves, and muscles. And cranial conditions and cleft palate malformations are going to be a big part of our topic here this evening. During this next hour, we have experts who are focusing and answering your questions about neurosurgery, oral and maxillofacial surgery. Did I say it right? Did I? We're having some fun with that before the show. There's a lot of L's in there, and it's hard to get it all together. As you guys know, this is a live program, so you can think of some questions of your own and give us a call at 881-0013. And we are streaming live on Facebook. So if you are a Facebook user, you can look for us on Facebook. Just look for the KCOS TV search bar, and then from there you can ask your questions on Facebook as well. And that's really helpful to people who aren't around TV all the time. This evening's program is underwritten by El Paso Children's Hospital. We also want to thank the Texas Tech Paulo Foster School of Medicine for providing students for us who man our phones, and as always, the El Paso County Medical Society, who's been producing and doing this show for over 22 years. Good evening, I'm Catherine Berg, and you're watching the El Paso Physician. Hello, thanks again for joining us. We have such an interesting show tonight, and if I don't know if we're able to, is there somebody behind that camera? Point the camera down just a little bit and check out all these colorful, oh, you're locked in. I just totally messed you up. Anyway, there's gonna be a show tonight that we've got a lot of brains on this table. We've got a lot of skulls, and every single skull that you'll see in a few minutes is from a real patient. So maybe that's like the teaser to come about to keep people, there they are. So all of these that you see on the table, every single one of these models of a skull, is there different, the cranium, skull is like the best word I can think of, but they're real people. And this is gonna be so neat because these are case studies that we have. I do wanna say very seriously, however, that there's gonna be some graphics that we're gonna show that are uncomfortable to look at, but they're real conditions. And if I don't say that and somebody faints and they'll get mad and they'll call, it's like there is too much blood or there is something out of the way, but we're gonna have some photographs this evening that are very good to see what these conditions are and how great this team at El Paso Children's Hospital is for being able to fix a lot of these issues and literally save lives. And we were just talking about that as well. So with me today, we have Dr. Jimenez, Dr. David Jimenez, and he is relatively new to El Paso, and he hasn't answered the question yet as to why he came. But we'll find that out soon. But thank you for being here. He is El Paso's only pediatric neurosurgery specialist, and so we thank you so much for being here. He is the medical director of El Paso Children's Hospital Pediatric Neurosurgery Department. And then we have Dr. David Yates, and he is the medical director of the Cranial and Facial Clinic at El Paso Children's Hospital. And then we have Dr. Vernon Burke. Not Berg, but we talk often because I get Burke all the time, he gets Berg all the time. It's just one of those names. And he is the chief department of the Oral and Maxillofacial Surgery and Pediatric Dentistry Department at the El Paso Children's Hospital. Thank you so much for being here and just going through what this program was going to be. Over the last week, I try to take a good 20 minutes here, 20 minutes there, but each time it turns into an hour here and an hour there researching this. This is fascinating what is new over the last 10 years. And I say 10 years a lot because I feel like it's a decade, but even over the last 3 or 4 years, the new ways of doing things and literally breaking the skull apart, if I can say that, cutting it, sawing it, how things are attached. I'd like to start, Dr. Jimenez, if I may, with you. If you were to describe what the discipline of neurosurgery is, and I know it's a lot, but say with what we're going to be talking about mainly tonight, for people at home to understand what you do all day, every day, and I know we can take 8 hours to say that, but if we can maybe put it into like 60 seconds, a minute and a half, etc. What do you do all day, every day, and explain to the folks at home what your specialty is.
Yeah, great. Thank you for having me here. It's great to be here. I'm 6 weeks old here in El Paso.
I'm 6 weeks old. I love it. Yeah.
So
And you get all the 100-degree weather days too. Goodness.
Yeah, but I'm very happy to be here. It's a great city, and I'm very happy I made the move. Yeah, so it's about taking care of children with conditions that affect the brain, the spinal cord, the neck, anything that affects the nervous system. There are a number of conditions, brain tumors, headaches of many different kinds, water buildup in the brain. And then there's a whole group of congenital anomalies that things don't go quite right in mom's wound, and then when the child comes out, they have all kinds of issues. So we address the whole gamut of those problems.
And there on this program too, we have, at least I feel with the way I was looking at, we have two of you that really specialize in congenital, and there's one that also specialize in injuries. Is that correct? Is that right, Dr. Burke? So we're going to talk a little bit about everything, but today we have a lot of focus on congenital issues. And again, fascinating. If we could, Dr. Burke, you're the jaw and trauma guy, right? And so that, when I say jaw, cleft palate is something that comes to mind with today's program. And so if you can explain to people at home what you do, and then Dr. Yates, I'm going to throw you in between the two, if that makes sense. Okay, Dr. Burke.
So the focus of my practice, especially my hospital-based practice, is to work on the bony tissue of the face. I do a lot of jaw surgery, I do bone grafting, I do a lot of trauma, and one of my particular areas of focus is to do distraction osteogenesis, which is the causing a fracture, very controlled, but still a fracture, and then growing bone slowly over the course of a few weeks to increase the length, to fix some sort of discrepancy.
So you are instrumental in growing new bone slowly? Am I understanding that right?
That's one of the main things that I do, that kind of I do aside from other people may.
Make sure we talk about that in case I forget, because that's fascinating. Because I know, again, that's not new, but I feel like with sci-fi, that was something that was going on 30 years ago in a movie, you know,
Right.
but it's actually happening now, and it's real world. I love it. Dr. Yates, how about you?
Well, I'm thrilled to be here.
Oh,
Thank
good.
you for having us here.
Well, you were smiling the second you were in here. I love it. I love it.
But we have like just such an amazing, at El Paso Children's Hospital, in the last couple years, we have built something really incredible. And we are the only nationally approved craniofacial team in about 1,000 miles. The closest is Phoenix, that way, and the closest in Texas is 550 miles away in San Antonio.
Wow.
And so there was so much need for a team that specifically has members that are actually world-renowned, Dr. Jimenez, and then Dr. Burke, and then also we have, not here is really 15 other members basically of our team, and they are all in their specialty. They give speeches on national levels, they give talks, and it's all right here in El Paso.
It's right here in El Paso. I love that. That's true. Are you an El Pasoan?
I am a transplant,
Okay.
actually recruited by Dr. Burke.
Nice.
But
Okay.
I specialize specifically in kids with facial and cranial deformities.
Okay.
And he really recruited me to come and, you know, be here so that these kids didn't have to travel 500 miles for a surgery.
And that's something beautiful too. Now I know that there's about 80% of all cases can be treated now in El Paso, and you're looking at reaching about 100%. Whereas before the Children's Hospital was around, it was about 40% that was able to be treated in El Paso. Is that más y menos right? I was just, again, that's the research part of me. You guys are like, yeah, sure. So thank you, Audrey. So I got that information from Audrey over there. Appreciate it. So on that note, so what I'd like to do is start off with, who wants to talk about the models on the table first? And I'm happy to take that from anybody. Who? Dr. Yates, you get that one, because you were kind of talking, you have this little tiny one in front of you.
Yes.
I have lots of questions here, but because this is the obvious thing, I like acknowledging the obvious.
Yeah.
And because we're going to talk about this, and we do have photos of people that these photos or these belong to, on that note, we'd like to go in order to keep everything easy. So I don't know if we're going to talk about this first, but in general, talk about these models on the table. How did you get them?
So these are all actually 3D printed models of specific patients. And these are 3D printed off of CT scans, which had been taken for any number of reasons. And all of these models show patients that exhibit some kind of craniofacial deformity or difference. And there's, each of us here at the table are experts in certain areas of treatment for all of these patients with deformities here. And some of them look different. So like this one, I'll just show real quick. And this is really cool to me because this is a kid who came and he had an increase in pressure on his brain. You can actually see kind of the gyri forming into the skull because there was so much pressure on his brain here. And this kid had multi-suture fusion. And basically you can
Hold it up just a little because this is the camera that's following you.
Perfect. The great thing about technology these days, and you were asking what's new in the last 10 years.
Right.
We can even virtual surgically plan these patients. And we plan where the cuts are going to be, which are all the pink lines. And then this is the projection of what the patient will look like after the surgery. And this is all done using the latest in computer modeling and 3D simulation.
And that again, just video too. And when you think about video games, and I'm trying to dummy it down a little bit, because sometimes people think, okay, that's 3D, and oh, mammograms now are 3D, isn't that great? And then, often we don't think of medical procedures done in 3D. When you get an X-ray, you see everything on a two-dimensional type of a screen. So when did the 3D technology come about? So I will joke a little bit this morning, has nothing to do with this, but this morning I had a 3D scan taken of the bottom of my mouth because I have some teeth issues, things are shifting, and I thought, wow, and I literally thought about tonight's program thinking, is this how they do that? You just scan, and then on the computer, as I was watching it, all the little pieces that didn't quite get scanned in by the camera that they had in my mouth were naked or red, and she had to go back in there and rescan them. And then when it was all said and done, it was truly a 3D picture of my mouth. So talk about that idea and how this is done with brains, because you can't get inside as you're doing the scan. So how does that, and Dr. Burke and Dr. Jimenez, I'm just looking at you because you're just the guy that was talking about it, but feel free to pop in on any of these.
I think for me, for my part, that when I graduated residency 8 years ago.
Okay.
And this was in its infancy for facial surgery. And we were just starting to do 3D scans that we could translate into stereolithic models and create this sort of thing. And then planning was still rudimentary. And then anything to confirm your plan in the surgery was also pretty clunky. And within a couple years of that, so 2013, we stopped doing any kind of analog surgical plans and went to virtual surgery.
2013. So this is like yesterday.
In my office, that's when I felt like it was valid enough to give up on analog planning. And now we do surgical plans like this, and we say, this is where we want things to go. And then we can even use an instrument called navigation and verify that the drill hole that we're gonna do is right where it was planned to be. And this is even more elegant in what Dr. Jimenez does. This is.
So I'm gonna go back to Dr. Yates, because I know Dr. Jimenez is very humble.
Yes.
And I'm noticing this as he's sitting next to me. And so there's some bragging that needs to be done about this man, and something tells me he's not going to do it himself. So Dr. Yates, you can start, and Dr. Burke, you can kind of piggyback, and you can just sit there and smile. And just, say, yeah, I'm that guy, Actually, you don't have to do that. Maybe we should not have the camera on you. But talk to me about Dr. Jimenez and the fact that he's in El Paso.
Yes.
And you have discovered several procedures, and that's being used today, not just here, but everywhere. So, Dr. Yates, I'm putting you on the spot.
No, I'm glad you gave me this opportunity.
Okay.
So, Dr. Jimenez in the world of craniofacial surgery is truly like a Benjamin Franklin.
Ooh.
Okay. And he has
I like it.
changed the way, but he truly has. He has changed the way we do this surgery.
Okay.
I mean, fundamentally. And his results are incontrovertible. And now places like Harvard, Boston Children's have adopted his technique. Places, literally dozens of places across the country have figured out that what he is doing, and he had a lot of controversy at the beginning of his career because people didn't want to accept this technique.
Yeah, it's new.
But it has changed the lives of children. And he really is world famous. We have patients come in. We had one come in last week from Amman, Jordan to El Paso. We have one coming next month from Saudi Arabia.
Wow.
And one from LA this week. We have them literally coming from all over the world to be a part of what's happening here at El Paso Children's Hospital. And
Nice.
specifically with what Dr. Jimenez has been able to bring to the craniofacial team.
Okay, so he's done the bragging. Now you get to talk about what that is.
Yeah, sure.
Okay,
Yeah,
Dr.
no,
Jimenez.
thanks for the opportunity.
Benjamin Franklin.
Yeah.
Just call you that throughout the evening.
Well, so it's really cool the fact that one of the things that attracted me here is I've been in San Antonio for the last 15 years, and I've taken care of a lot of kids from El Paso. So I know
Good
the
point.
need here is tremendous
Yeah.
as it pertains to neurosurgery, right? And I've had so many kids who are, imagine this, right? You have a baby, baby has a brain tumor. You have to get in a car, drive 9 hours to go see a doctor over there. He operates, kid does great, you come home, all of a sudden they get sick. Now you have to get on the car, the kid's throwing up, you have to drive or get on a plane. That's terrible.
Yeah.
That's what I saw.
Yeah.
So I knew there was a tremendous need here. Children's Hospital, it was the right time for them.
Right, exactly.
They wanted then to say, well, we need to build this program. We need to fill this void. And for me, it was the right time. And life is about timing, isn't it?
It is.
It's all about timing. So
Just talking about that this weekend.
the
yeah.
timing was perfect. And so I'm really thrilled about the fact that people were leaving here to go get medical care, and now in 6 weeks they're flying from all over the world to
Yeah.
El Paso to get the care.
Right?
Isn't that great?
It's very great, yeah. And I thank you as a mom. Granted, my little ones are grown up, but eventually they'll have little ones. So
Right.
thanks for being here. I mean,
Right,
thanks to
right.
all of you, because that's a big deal. To ask the next question is, to me, the hard crossroads now, because I don't know which way I want to go. I almost want to start with some of the graphics that we have here, because I don't want to not get to them, if that makes sense. So if we can pull up the PowerPoint slide, so there's cleft, and it's going to be cleft 1 and 2. So the first one will be this photograph that's going to show up and on the monitor, so so that's what's live. So that's on the monitor there. Who would like to talk to us about this grouping of photos? Yes.
I can talk about cleft. So
Okay.
cleft lip and palate is the most common craniofacial deformity
Okay.
in the world.
1 in 700, I understood. That was far more than I expected when
And
I looked
that's
that
in
up.
North America. But when you actually take a look at populations like Native Americans have a much higher incidence.
Huh.
And Hispanics also have a higher incidence. So really in El Paso, this is a huge need.
Yeah.
And one of the most important parts of why we need a comprehensive team, which is also nationally approved, that treats kids like this. But this is a little kid from our community who had a cleft lip and palate, and he's been treated by our team. And
So this age, the first one, is a couple of months old?
yes, that's actually
Okay.
pretty much a month, less than a
month.
month old. That's
Okay.
newborn.
Okay.
And then we do the surgery around 3 or 4 months of age after Dr. Holguin.
That early?
Yeah.
Okay.
And we are very fortunate to have someone who does nasoalveolar molding, which makes the surgery a lot easier.
Okay.
And her name is Dr. Holguin, and she actually shifts the lip much closer to each other, making less tension on the wound. They just sent a team from Harvard to come observe how she does her technique.
Oh, nice.
It's very cool.
Okay.
And so that's a little kid from our community who we recently treated his cleft lip.
Okay, so on that note, how many people come in and how many surgeries, number one, does it take? And I know it's different with everyone, but let's just talk about, so she helped bring the lip together a little bit more, and then other surgeons come in and do different things. So just as in this particular case, how many surgeries did it take, I should say, to get him to this point? And so he's probably, I'm looking at 2.5-ish here?
Yes, so
Okay.
that's just 2 surgeries.
That's just 2 surgeries.
So we did the cleft lip repair
Okay,
around
yeah.
3 or 4 months.
Okay.
And then you want to do the palate between 10 and 18 months. Right when they're learning how to speak, you close the palate.
I see.
And then,
Okay.
do you want to talk about the sequence of the others?
Right. So, kids maybe 7 to 14 surgeries, somewhere in there, depending on how things go, between the time they're born and about the time they're 18. So after the palate is closed, then you monitor their tooth development, actually. And then once you close their lip and you close their palate, they still have a little defect here in their alveolus, or where their jawbone meets. And they'll have a little hole that goes from their mouth to their nose at about 6 to 9 years old, you'll close that and put bone there to join the two parts.
Okay.
Then you may need a lip revision as they grow. And then what I'm very excited about is myself and Dr. Yates for the past 2 years have started doing what's called skeletal anchors, or we put little bony anchors on the lower jaw and upper jaw. And these kids oftentimes have a relationship like this model, where
And again, point at that camera if you would. Or, yeah.
I'm new to this.
No, it's good. That's why you get directions. It's
So
all
their upper jaw is smaller than their lower jaw. And so instead of doing a surgery where we put these on, we put these little anchors on and put rubber bands and grow the jaw forward so we can avoid a larger surgery later.
nice.
And if we can do that, it saves them a major surgery. And then they'll maybe need another lip revision, some bone grafting for dental implants, a rhinoplasty, maybe some speech surgery mixed in there somewhere to help them, because a lot of them have a little extra problem with forming words
That makes
and
sense.
certain sounds that they need to form. So those are all mixed in there, and you have to tailor what you do to the child to what they need you to do. It's not formulaic. So.
They have, thank you very much. We're starting to get all kinds of questions from the audience here. Again, I don't want to bypass, so we have, and I don't know if this is, so I was looking up something called, is it flathead? And I don't want to say that wrong, but flathead syndrome, and I don't know if this is the third graphic that we're looking at. But if we could pull up the third graphic, just because we have all these and I want to make sure that we get to them all. Sorry, I keep looking at the camera, but it was up a second ago. But in general, again, when you're looking at this one right here, so if you're looking at the forehead, what's happening here in this photograph? Dr. Jimenez, everybody's looking at you. Did you see that? Did you see both of those guys? They're like little boys going, Dr. Jimenez.
By coronal.
Bicoronal.
So just to go back and give you sort of an idea, when the brain, when we're born, right, the brain grows extremely rapidly for the first year of life. So say if you're 6 feet tall, that in 12 months you're going to be 12 feet tall. That's a tremendous amount of growth, right? So the brain grows very rapidly because it's a round ball, we don't see it as much.
Right.
Well, as it grows, it has to go somewhere, right?
Right.
If it's inside something as solid as this, like a cast, it won't be able to grow, right? So we have these little cracks in the skull that passively enlarge, allowing the brain to grow. And then the skull grows around it and it stops around 18 years of age. Well, at 18 years of age, each one of these cracks, called sutures, sense that the brain's not growing anymore and says, okay, time to close up shop.
Okay.
But if the suture, say the kid is a month old or 2 months, thinks that he's 18 years old,
Oh my goodness.
it shuts
then
down.
It just stops. Okay.
Well, but the brain's growing. So what happens?
Right.
It gets deformed, and that's what you see in those pictures.
Okay.
In that child, both of these coronals, so the one that goes from here to here and here,
Right.
stop growing, so the face cannot go forward. It grows up. Everything gets flattened.
If we're able to put that graphic up again, it'd be graphic number 3, if that helps Gracie. Gracie's in the back, and she's a superstar today because this is a lot of stuff to deal with. So, okay, so we're looking right there that there's no place.
So
Like
you
you
can
said.
see the child is, the forehead is flat, is very tall, and is very wide. Because the brain is trying to grow, and the only place it can go really is upward and sideways.
So in this situation, the team does what? So we were talking about, and Dr. Yates is nodding, so that means you get it. If you nod at me, or if you wink at me, or you smile at me funny, it's your question. So what happens now?
So at this point, whoever
Yes.
sees this child
Right.
and notices that something is wrong with the head shape
Right.
should refer them to our cranial and facial surgery clinic.
There you go.
Where they can see a range of specialists that really, specialize specifically in craniofacial disorders. Now this girl, and I think she's a good one to talk to, and I really want to segue into something Dr. Jimenez invented. So she presented to us late at 4 years of age. She was actually sent to us by her ophthalmologist because these sutures had fused. She had so much pressure on her brain that she was in jeopardy of going blind
Oh, goodness.
and possibly
Okay.
even dying from this condition. And so we urgently did surgery.
Okay.
And if you go to the next graphic number 4.
So graphic number 4, yeah. So this is the Yeah, just graphic number 4.
This is the computer image, and you can see that there's that squiggly line that Dr. Jimenez was talking about is missing on her. And so we needed to move that whole forehead forward and get more room so that her brain could grow appropriately.
Right.
At this point, we then did a surgical plan, and if you go to the next graphic, you'll see
So
that.
graphic number 5.
And those were the proposed cuts that we needed to make. And then go to the next graphic as well.
And number 6.
And then that's how we
Wow,
were
look at
moving
that.
it forward.
Okay.
And this is done in conjunction with a craniofacial surgeon and a neurosurgeon at all times.
So when you're talking about these cuts, and pardon my ignorance because I don't do what you guys do, so these open spaces, is there a tissue that is then protecting the brain, or is this just how, because I'm looking at that and it just looks really open to me, and now I'm just waiting for something to fall in there, like it's the kitchen table and Fido's not downstairs to catch all the food. So what's happening with all this open cracks, Dr. Jimenez?
So we have a skull, we have the scalp, and underneath we have the skull, and then below that we have a membrane called the dura mater. In Latin means the hard mother.
Okay.
It is like
The hard mother, I love that. Okay.
It's the mother of the brain. It protects it, and it's like leather, very
Okay.
hard. And then below that is the brain.
I see.
So what we're doing here is we're making cuts on the bone itself, leaving the dura intact, protecting the brain, and then mobilizing the pieces of bone and sort of recreating new cuts and new sutures to then allow the brain to grow.
Okay. So this then, the brain, and I think to myself, bones, when a bone is cut or a bone is broken, the bone naturally just wants to grow and heal itself.
Right.
Is there something that you have to do in this situation so it does not regrow into itself, or like the sutures, or I don't even know if that even applies. It's just something I'm thinking out loud. When a bone breaks, because it's so close to each other, does it want to just gravitate back, or?
It does, and the body heals itself, and bone is no different. So yeah, eventually we do want it to fuse. We don't want holes there.
Okay.
And over time it does that, yes.
And
But
I guess at the
hopefully
same
by
time
that
too, the
point-
brain's expanding it out because the
Right.
brain's wanting to grow.
And at that point, that we've gotten the shape that we want.
Okay. Nicely said.
But this pulls us into, I think, a conversation that is very beneficial for this entire talk, which is if these kids, that's a big surgery,
Right, of course,
Now,
yeah.
it was a necessary surgery, and she did fantastic. And now she can
On that
see.
note, we have to put up slide number 7 because it's just super cute. But yes, keep talking.
So she
Yeah.
did fantastic, and she has no more threats to her vision or her life. She's done wonderfully. But if these cases are caught early, we can do a much smaller, minimally invasive surgery. And this is the surgery that was invented by Dr. Jimenez. And I think it's a great time for you
Go.
to talk about it if
Yeah.
you want.
You get to
Sure.
talk about Dr. Jimenez. I'm going to move this out of the way.
Okay, so let's think about it, right?
Yeah.
Typically, there's 3 reasons why a baby's head looks funny
Right.
when they're little, right?
I remember the cone shape. Yes.
Right, cone head.
Yes, cone head.
And that
One of
is
mine was a cone head.
That's because why? Coming through the very tight birth canal, the head gets all squished, right? And the reason for these sutures and these cracks is to allow the bones to shift so the baby can squeeze through the birth canal and then come out. Then if the baby looks funny, what we call them FLKs, funny looking kids, right?
Oh, yeah.
If they look funny to the pediatrician or to the mom, well, just wait a couple of days, right? Wait a week or 2 weeks, and if it's from birth, it should round out and look normal. The second one is from positioning. If the baby lays in a certain way for a long time, gravity squeezes the head and they get deformed. The third one is from a craniosynostosis, where the suture closes and the deformity takes place. So typically the pediatricians and the parents kind of wait, and we say, well, maybe it'll outgrow it. And then by the time they get to us later on, like this little girl at 4 years of age, we have to do this big surgery as well. They're great to do.
So what does the suture, what causes it to close when it's not supposed to yet? Like, why would that close in some cases
Well,
and not
I
in
think
others?
you're gonna have to ask that God.
Oh,
'cause
you have
he's
to
the
ask
one that
God
knows.
that question,
He knows
yeah.
that. But it's
I've
but
tried
it's
to
really
call a couple of times.
No.
Yeah.
We know it's genetic.
Right,
We know it has
okay.
to do with certain receptors in dura, and it's very complicated
Okay.
chemically and at that level. But what triggers the gene to do that, we don't know.
Okay, gotcha.
It's not anything that mom does or drinks or smokes or anything. It just
Right.
happens to a certain percentage of the population.
I love that. You just have to ask God. I think if
Right.
we can't answer a question
Well,
from here on
right.
out, that's totally going to be the answer. I like that one. Dr. Burke, you haven't talked in a while, but you are nodding your head violently, and I love that. So is there anything that you'd like to add onto this?
I
know
was
we're gonna go
learning.
this- Oh, you were learning. I like that. I like that. So I'd love to go to slide number 8, because there looks like there's a lot of different issues going on here. And maybe not different issues, but one issue that's affecting different areas of this. So that's the mouth that's being affected, the nose is being affected, the eye sockets are being affected. And this is actually the person I saw this morning. I don't know if I'm allowed to say, let's say Dr. Wilbanks worked on this. I was with him this morning just working on some other stuff, and I was talking about this program. And so there, again, there's a lot going on dentally too. So we think about facial, cranial type surgeries, but then there's a lot going on with the teeth, talking about speech, but just the simple act of eating is a big deal. So who wants to take this on first? Dr. Burke, it's yours. Excellent. What are we looking at in this slide here? And what's, I guess let's first discuss what this condition is, if it has a name, and all the different things that are going on within this child. Because again, I'm looking nose, eye, mouth area. I don't see much above the brows, but maybe there is, but I can't see it from here.
Well, you can see, starting from the top down, that his eyes are very far apart. So
Right.
in what's called hypertelorism. And he actually has no vision in his left eye. So a subsequent surgery where you would change the position of the orbits may threaten the vision in the eyes. So if he's only got one eye that has vision,
Make
you
sure
have
that
to
one's
factor that
okay.
in, and that played into his case.
Okay.
And then we called this a Tessier 01 cleft, yeah. So you can see that his nose looks bifid, like almost like he has two noses. So it's like a cleft lip, but it's in the center of his forehead and his nose.
Okay.
And then he has this protruding upper jaw,
Right.
where his teeth don't meet well there. And so we needed to try to do as much for him as we could in a small period of time,
Right.
and in one surgery. And it really took a team effort. There were a lot of people involved in his care, and I got to give Dr. Yates credit. He did a lot of the background work to make sure that Malik was taken care of while he was here.
And Malik is from Palestine. Did I get that
Yes.
right earlier?
He
Nice.
is.
Hi, Malik.
And so we felt like what we could really do to help Malik out was, first of all, fix his nose. It was one thing that he was very self-conscious of. We stayed away from his orbits because we wanted to make sure we maintain his vision, and that we could get his teeth together, make his smile a little bit better, and definitely make it so he could chew and eat
Right, exactly.
and speak in an improved way. Dr. Olgin, of course, got involved and did restorative dental work on him. Dr. Wilbanks, we took out a couple of teeth so he could get him ready for surgery, which he did unbelievably fast. And then, several other people. He had a host family. There were a lot of people who deserve credit for his care. And then, the Children's Hospital donated their services.
Yeah.
And, Texas Tech, helped out with, anesthesia services. There were a lot of people that got involved behind the scenes and right directly in his care.
And I
so,
imagine every time a case like this comes up, it's a fascinating learning experience to everyone involved.
Right.
Because it's not an everyday surgery. And Dr. Yates, I would love to know from you, as Dr. Burke gave you beautiful credit for, so the pre-surgery. So you were talking earlier about all the things that you can do via scans and via planning out a surgery prior to it actually happening.
Right.
Kind of take us through that. You touched base on it in the beginning of the show, but that's really neat. I don't know, is Malik on here?
Yeah.
He is. There's Malik. Yay, Malik. Okay. So I just love him. He's just got the cutest smile. You'll see a great smile with Malik later on. But talk to us about how the planning goes prior to the team then coming in and when you said one surgery, I'm thinking in my head, I thought there's like 4, 5, 6 surgeries here. But
The problem with Malik is that he was coming from Palestine. There's no craniofacial surgeons, pediatric neurosurgeons in the entire
So you were the
country.
first point of any kind of true medical help here.
Yes, we were. They know that we do these kind of surgeries, and we have taken care of other Palestinian kids. And they reached out to us through the Palestinian Children's Relief Organization. And there were literally 15 people on the team who donated their services, the El Paso Children's Hospital, as Dr. Burke said. And really his concerns were how his jaws fit together. What he said all the kids made fun of him for was his nose and how his jaw fit together. But he had unilateral coronal synostosis. He couldn't hear from the left ear. As Dr. Burke mentioned, he was blind in the left eye. And we only had like 4 months to get everything done.
Oh my gosh.
And so usually these ortho cases take up to a year to plan and get ready. But we were able to, with Dr. Wilbank's help, rapidly get everything going. And then we planned, and if you go to the next slide, you can see actually the surgical plan for Malik. And you can just continue scrolling through those slides a little bit too. And Dr. Burke, actually, we both planned this one together.
And Gracie, just go in order if that's the easier way to do it. So no, you're good. So this is good. No, so 10 is perfect. And so from here, you're looking at the different planning of the stages. So this is mainly teeth, am I seeing that? I don't have my eyeglasses on, but yeah.
I'm going to let Dr. Burke talk about
Okay,
this, actually.
perfect. Thanks, Dr. Burke.
So we actually planned this together. We did take out a tooth in the upper jaw on each side, and then we needed to get his teeth together. And so what you're seeing with each color of the upper jaw is us separating the upper jaw into 3 segments and then placing it on to the correct bite on the lower jaw. And then what you don't see in the image there is that we will put little tiny plates and screws that connect the unfractured part of the upper jaw to the new fractures, so that it can heal into that position.
Right.
And then then the rhinoplasty took place after that.
So I'm trying to get my head around timing because you're talking about healing. So you're talking about the screws and you're talking about the healing going around there. So if you're looking at bone healing enough to where then you can have an additional surgery, and you said from beginning to end you guys had 4 months?
We had 4 months.
Goodness. So the planning and the surgery, and so from the time he was here and went home, this is what you guys had to do. Okay, so now we're talking about this first surgery. The second surgery, how much later?
We did it all at one surgery.
This is
the
completely
first
all at once.
phase of one bigger surgery. And so we put his jaws in the correct position. The little plates and screws hold it like an internal cast.
Okay.
So they hold the bones in position, and then the bone heals into that new position. And at the end of 6 weeks, he can eat and do everything that he did before. And
okay.
Yeah.
So I'm going to, again, prep the audience because these next 2 photos have a little bit of blood and, tissue and all that kind of stuff. So if you're queasy, look away. But 11 and 12, let's put 11 up first, and we can describe what all the stuff that we don't get to see from the first couple of pictures we're going to be looking at here. So slide number 11 is the pre-op, and then there's one that's, let's see, put that up. So yeah, whoever wants to talk about this, do.
Well, yeah, I mean, you
The
can see
alignments,
that
yeah, I
when
can see that
he's
there.
biting down,
Yeah.
that his front lower teeth are biting into his palate.
Exactly.
So if he tries to bite down normally, he bites himself. And that his front teeth, he cannot bite into food effectively because they don't meet.
Right.
And he has this spacing, and in order to make certain sounds, your teeth need to meet in the front to close off that in conjunction with your tongue and your lips.
And you're talking about speech to make
In
certain
speech,
sounds with
right.
speech.
So
right.
there's several things that are wrong or could affect his function with this sort of setup. So
And then the next slide, if we can go to that.
So the next slide, this is actually his rhinoplasty portion.
Okay.
And he had a very, very complex nasal deformity. He had a cyst in the middle of his nose. A lot of the normal anatomy was totally obliterated. And so what you're seeing here, actually those struts, you see it looks kind of like a teepee on the right.
Right.
You're looking at his nose from looking down the top of his forehead. And we had to use a cadaver fibula, so that's a leg bone from a dead person,
Okay.
to reconstruct the nasal dorsum. And then those those 2 things that form the triangle, those are actually ribbed from a cadaver. It's cartilage.
My goodness.
So we had
Okay.
to completely reconstruct his nose because there was nothing in there. And we were able to do that, fortunately, using the tissue bank. And then we cover it all up, and that was him on the table right after he had had the procedure, the jaw surgery and the rhinoplasty at the same time.
Look at the difference in all of that. So this is, how long did this take? Like a day?
Took us 7 hours.
Okay. So that's a 7-hour difference there. So that's 7 hours pre and then 7 hours after. That's amazing. And so when you're using tissue from the tissue bank, and I guess this is, I'm just thinking about the pre-planning of all this. There's measurements, there's trying to figure out exactly how big these bones need to be cut to, and again, I'm trying to put my head around and I can't. I think we need to have 18 more of these shows and just take it case by case. But it's amazing because if you're looking at the way his nose is reconstructed there, and you're taking out the middle, so the palate, when you're talking about the cleft palate, closing that up on the upper part of the mouth and then into the nasal cavity. So tissue, so I'm thinking about tissue healing at this point. So you had to open up tissue and insert bone. And is there any bone rejection concerns, or is that even a thing with cadaver bone? I know it is with organs, it's a concern, but I'm just throwing that out there because I'm just thinking the questions that I would ask if this was my kid.
So in the donated bone, there's not been a case of disease transmission in donated bone in the United States. And the proteins during the process of preparing the cadaveric bone, the proteins are mostly removed. So all those proteins that would cause rejection are also removed. So the body slowly makes that cartilage and that bone into his bone and cartilage. His body will replace those tissues into his own.
Okay. Nicely said. All right, believe it or not, we're at 15 minutes before the show ends. I know, it happens so fast. So what I want to do, and what I may do, Gracie, I'm going to talk really quick, and Gracie just in the back, I may just finish on slide number 19 just to kind of prep you a little bit. Dr. Jimenez, I feel like we need to talk to you more because I want to know more about you and your procedures. So both of these are bragging about your procedures, and these are what we're talking about here. And specifically, what was your, I don't want to know how old you are, but when there was a time when you thought, you know what, we need to invent, create, figure out how to do procedure A, B, and C, talk to me about that process in your head. What was it that you were seeing that was not able to be done? And you and maybe friends, team, were putting this together. What exactly was that, if you can explain to the audience? Because I know there's frustrations in the medical field. It's like, if only I can have that direct line to God and say why. You know, so what was it in your head? It's like, okay, I really want to fix this. What was that, and how did you go about doing that?
Well, one of the reasons I went into pediatric neurosurgery was because I was fascinated by doing these big surgeries. Okay, craniosynostosis. I mean, from a surgical standpoint, right, David? It's great to take a kid's head apart, cut it into a million pieces.
I'm glad you think it's great. That scared me to death.
Put it all back together and get a pretty good result. But the challenge, at least as I saw it, was that the results are not consistent. Some kids look good, some kids look okay. A lot of the kids did not look good. They looked, and studies have shown that if you follow them over a long period of time, they end up getting worse and worse and worse. So that was one thing. And then the trauma that we put the kids through is pretty significant. I mean, massive blood transfusions, a lot of swelling, a lot of pain and all that. So the thought was, well, could perhaps, I did a lot of training and I did a lot of work with endoscopes, which are miniature telescopes in the brain. So instead of doing, say, taking out a brain tumor, instead of taking out half the skull and doing all this dissecting, going in through holes the size of a dime, using lasers, using sort of tiny, tiny incisions. So I said, well, maybe using minimally invasive techniques with endoscopes, what if we applied it to this? But instead of waiting until the kids are 9 months, 10 months, a year, what if we get them when they're like just a few weeks old? And then we just release the suture and let the brain do its work. Because the brain knows better than we what the head should look like.
So you physically go in and just allow that part of the bone that's closed, it's not allowing it to grow, you just open that up and allow.
Open it up.
the shaping to occur.
Exactly, and then we
It
use
sounds so simple,
Right.
right? But it's not.
and
it's
then we, and
not.
then we use and then we use special and then we use special helmets,
Right.
because we know from the Egyptians, we know from the Incas that you can change the shape of a baby's head any way you want.
Right.
If I want a baby with the head of a pyramid, I just put him in a special contraption, and the kid will look like a pyramid.
Yeah.
Right. So the thought is, well, if the kids are misaligned and deformed, and if we release the suture and then let the brain do what it wants to do, if we put them in special helmets, could they go? And the
It helps
answer is
facilitate
yes.
that.
So the beauty of it is, if you suspect that your child has a problem, or if the pediatrician suspects it, just send them over to us. We'll look at the kid, and if it's normal, great. But if it's got a problem, then let's get to him early. We can do the surgeries very quickly. We do the surgeries now in 45 minutes, under an hour.
Oh my gosh.
The baby stays overnight,
Okay.
except for the one kid. Just when I got here, I hadn't transfused a child in over 12 years.
Oh.
And the results are fantastic, right?
They're phenomenal.
So when you say transfused a child, so
So in a lot of these surgeries, we lose a lot of blood.
right.
Well, we don't. The kid loses
Right,
blood, not
right.
we.
I'm with you. Yeah.
Yeah.
And there's not a
Right?
lot of blood in them in the first
Right.
place.
Right.
So- right,
Goodness.
Exactly.
Yeah.
So if you look at that cup right there, this cup right here, this is about how much blood a baby may have.
Oh my gosh.
So take
Okay.
a sip, they lose a 10%, 20%. So it doesn't take a whole lot of blood, and the baby's unstable, so we have to transfuse more and more. So almost 12 years, I did not give blood to a single child,
Wow.
which is good.
Yeah.
But most important, I think, is that when you follow these kids, and I'm following them now, and this is great. Facebook is great in this sense for me anyway. Is that these kids are reaching me on my professional Facebook page and sending pictures of their graduation, going to school, and you look at them and you can't tell there was anything wrong with them.
Really? Oh my
Yeah, it's
gosh.
great.
And you're that guy then. Do you have the Wall of Fame? We call it the Wall of Fame, but it's anybody that you've helped and fixed and throughout the
yeah.
years. So that is
Yeah,
absolutely beautiful.
yeah, if you go on my Facebook page, you'll see it's.
Should we give it
pages and
out? Should we
pages of
let
it.
people know what your
Yes,
Facebook
it's
page
just
is?
my name.
Okay, so that would be David Jimenez?
David Jimenez, yeah.
Okay, David Jimenez at Facebook.
MD, yeah, Facebook,
There
right.
you go, MD. And
then-
again, we're streaming live on Facebook now anyway, and that's nice. So just look for KCOS TV, and in there you'll see the El Paso physician. Again, you can ask questions live. And on that note, we do have a couple of questions here, but we're running out of time because this really could be. I mean, I'm almost dissecting how we can do different shows doing this. We can do one show just doing cleft palate, cleft lip.
Absolutely.
On its own, and then we can do another show just on different syndromes. We can do. This is fascinating because this is new to us. It's new to me. I've been doing, like the audience knows, I've been doing the show for 22 years. Wow. Right before this, show started, my 22-year-old called, "Honey, I gotta go," but she was 3 months old when I started the show. Oh, wow. In that amount of time, we've not had a show like this.
Wow.
So thanks for being here. And I'm not just like blowing smoke up your skirts because you don't wear skirts, but please come back. I would love to have this. I have here, and I'm reading this cold, so my apologies. I have a patient on the line, 78 years old. This is Children's Hospital, but I'm going to have some fun with you. Patient is 78 years old. They were attacked multiple times in their preteen years, teenage years, and then adult years, hospitalized several times. How or what about the brain provides protection against harm that enables this person to still be functioning more or less normally? And that's I can see that being a nice pediatric question. And I know we talk a lot about concussions now and sports, but let's just talk about, and Dr. Burke, I'm looking at you with trauma. When there's a lot of trauma to the brain and neurologically, and I know that's a whole nother thing to open up in this small amount of time, but neurologically, what are some of the issues that can happen when you have repeated trauma to the head?
Well, probably Dr. Jimenez is better to talk about neurologic injury.
Okay.
As far as the face is concerned, the face acts as almost like a crumple zone to protect first of all, the eyes, and then also the brain. There's multiple places in the facial skeleton that are air-filled, sinuses, and the cheekbones, the nose, all these can fracture in, yet protect the vision and the brain somewhat. So for my part, that's a lot of times what I'm doing is kind of reinflating the crumple zone.
I love the crumple zone. That's my takeaway for the evening. So if you have a black eye, or it's good. It protected you.
At least your brain.
My daughter, I mean, she was a cheerleader, but she was the tall one, right? So she's the one catching everyone, and her crumple zone got hit a lot.
Saved her brain.
It did. It saved her brain. So that's what I'll tell her going forward. We have a whopping 7 minutes, specifically to the neurosurgeon, which is caller has a grandson with hypokalemic periodic paralysis, which is mostly, so this is we only know what's on here. So we do the best that we can what we have. I should have said that before. Okay. So I don't want to freak you out or put any pressure on you. But again, so the grandson has hypokalemic periodic paralysis, which is mostly managed with a diet. Caller wants to know if the physicians have encountered or treated young adults or adolescents with this condition, since it's so rare. Again, if you know something about it, great. If not, we can move on, because again, I like to honor the questions from the audience.
Well, that is a medical condition.
Okay.
So we divide the things that we treat broadly into two areas. Is it a surgical condition or is it a medical condition? So for instance, you have a headache. Mm-hmm. If you have a brain tumor that's causing the headache, that's a surgical condition.
Gotcha.
Because surgery will fix it. If you happen to have migraines, well, I can operate on you 10 times and guess what? You still have a migraine.
Right.
So that's a medical condition. So that, what the caller is referring to, is medical and is managed with medicines and diets and all of that.
Okay, and that's how they're managing right now, it looks like. So we're at about a 5-minute mark before the show wraps up. So what I want to do is stop everything here for a second. And Dr. Burke, because you're on the end, I'm going to start with you. Is there anything that we haven't talked about yet or haven't touched base on, or something that we have that you'd like to maybe talk about before the end of the program? And all three of you will have a shot to do that. And if not, then not. I'll go to questions. But I always like to give you guys a shot at thinking, okay, I'm driving to the TV station. I want to make sure I say blank. And have we? And if we haven't, maybe we can talk about something adequately.
I think that what brought me to El Paso was the same thing that brought Dr. Jimenez here, is that I was in San Antonio and treating kids from El Paso. And I came here to stop that. And I think that you saying, in all the years that you've been doing this, you haven't talked about this. And that's because it wasn't being done here. It's not that it didn't need to be done here. It's that the kids were going somewhere else to get it done. And now the team that's assembled here, and we are definitely in Dr. Jimenez's shadow. I worked under him at San Antonio, and I was proud to have been in the OR with him, and we're very lucky to have him. And I recruited Dr. Yates to complete our craniofacial team, and he has done immense work since he's come here and superseded what I'd hoped he would do. And so we have what El Paso needs here. There's no longer a reason to leave, and actually there's a reason to travel from other places to come here, and that's what people are doing.
And I love, Dr. Jimenez, how you said, you got to get in the car, drive 8 or 9 hours, and then something happens. That in and of itself is medical, but then there's also the support system and the emotional toll that has, because then all of a sudden you don't have grandma and your aunt and your brothers and your sisters, your entire, and especially when you're young, that's so important. So even though that's the sappy emotional part of the evening, it matters, and it matters with every kind of recovery, it matters with every kind of illness. If you're able to do it at home, where your support system is, where the people that you love are, that is such a big deal. And so I don't want that to get lost on everyone who's in this area, that you can go to some other place, but the big part of healing is the support that you have. Dr. Yates, anything that we have not talked yet about?
The only thing I would like to address, I think, is, you had mentioned earlier, like 80% of stuff is now able to be managed in El Paso, but truly in the head and neck realm, 100% can be treated, and not at an okay level, but at the highest level of anywhere in the world. And I really believe that.
See, that we didn't touch base on tonight. That would be a nice program, because that in and of itself, that is such an issue, such an issue. So come back is what I'm saying.
Okay.
So when you talk about head and neck, and I'm just thinking about all these more, because I have down here too, all the different syndromes that are here, and but we didn't get to them, which I respect because it's just so much to get to. But when we're talking about neck and neurology and malformations, because we're talking about the brain right now and the sutures closing too quickly, but that kind of stuff can happen throughout the skeletal system, correct? Is that?
Absolutely.
Yeah.
And other people also in our group, we have some, well-trained microvascular surgeons. Dr. Hans Brockhoff, no one was doing that surgery before he came, and he's at El Paso Children's Hospital. These are all people that people were going out, but now all of that can be treated here. Nice. And you will not find a more passionate team of individuals, I think, than the people on our team who donate time and effort and money to make sure that these kids are really taken care of at the highest level of anywhere in the world.
You know, I'm kind of from the news background. We used to always say, if there's a story about puppies and children, it's on the air. So good job. You guys are treating the puppies and the children. And there are puppies too. Dr. Jimenez, you get the final word. Anything you'd like to say?
Well, I tell you that I'm very happy to be here. As I said at the beginning of the show, the opportunity to make a difference is here. You know, I could have gone to New York, LA, but this is where the need was, and it takes a village. It's not just a person, and having highly trained individuals like Dr. Berg, Dr. Yates, and everyone it's great. I'm interested in not just coming here to do surgery, because I can do that, anybody can do that, but I'm interested in building a program that then will stay here forever, providing care of the kids. So when I'm gone, it's not like we're back to square zero.
So 22 years from now, we can talk about this.
And one of the reasons that attracted me about coming here is the children's wanted to build a program. They didn't just want to bring a surgeon to the surgery.
Right.
So that's my goal here, and we'll talk about it another 20 years maybe.
No, yeah, well, and that's what I'm saying. It's beautiful. I mean, it starts here, and mark this day, right? Mark June 1. Is that when you first came here?
Yeah, June 1st.
So mark June 1st, 2019. It's like, when did things start in El Paso, Texas? Well, let me tell you, June 1st, 2019. Remember that? And then we had the show on July 18th. Pretty nice. We have 30 seconds to go, so I want to say thank you again, Dr. Jimenez, Dr. Yates, and Dr. Burke. Again, if you want to watch the show once again, you can go to the El Paso County Medical Society site, or you can also go to kcostv.org, go onto watch, into programs, find this logo, you'll find it. And again, I'm Catherine Berg. We've been talking a lot about children, all these heads on the table. Thank you for being here, each and every one of you. You've been watching the El Paso Physician. Happy dog days of summer. Good night.